Hello everyone and welcome back to Clinical Cousins YouTube, where today we're going to put everything together. Yes, we are going to talk about blood pressure, the arterial kind of course, with systolic and diastolic numbers, and we're also going to see how we can calculate the mean arterial pressure and its clinical significance for our patients. So we've all seen these two numbers on the monitor, the top being systolic and the bottom being diastolic. Now, we know that for an adult, the average blood pressure should be around 120/80 or maybe a little bit less. We also know that when we have high blood pressure, it's bad. And when we have low blood pressure, it's bad. So, how does our body tightly regulate these pressures to make sure that we're not having too high or too low blood pressures? Well, we have to ask ourselves, what factors help determine blood pressure in the first place? Well, first, systolic refers to the maximum pressure that is in the arteries. It's the highest pressure we get. So systolic refers to the contraction, the squeezing of the ventricle. We know that it's called systole. So when the ventricle has squeezed out its stroke volume, the pressure in the arteries, this is where our blood pressure cuff is. The pressure in the arteries is the highest. Why? Because they're most full of blood. So we remember from our previous videos that arteries, they're not very compliant. So with each little bit of blood volume from the ventricles, their pressure will increase tremendously. So this is our top number. This is the maximum amount of pressure that our arteries have to deal with when our heart squeezes. So important. So you can remember this by saying to yourself, this is the squeezing systole number. Now, what about that bottom number? Well, we know that this is called the diastolic blood pressure because it is the lowest pressure in our arterial system. So when does the lowest pressure occur? Well, remember the difference between compliance, pressure, and volume, but simply it occurs when there is the least amount of blood. You can see that the heart is kind of getting full, it's not squeezing. We know that this is called diastole. Okay, so this should all seem pretty simple if you're familiar with blood pressure or if you're practicing right now. Well, it should, because this is what everyone knows. Well, we're going to look at the factors that actually influence our systolic and diastolic numbers. So let's start with that systolic. Well, what are the main influencers? Well, we have to ask ourselves a few questions. Well, we know that the systolic number is really dependent on the amount of blood that our arteries that our ventricles squeezes out. It's the amount of blood that is entering our arterial system. Well, what do we call it when we have blood per minute that is entering our arterial system? That's right, this is the cardiac output. We know that the cardiac output is simply heart rate times stroke volume. It's deceivingly simple, but meaning that this is the number of heart squeezes in 1 minute times the amount of blood that the heart squeezes out with each beat. So just to give you some ballpark numbers, this is usually around 72 beats per minute at around a stroke volume, remember the amount of blood that we're actually squeezing out with each pump, of around 70 milliliters. So if we multiply those two together, they give us just a little bit over 5,000 milliliters of blood per minute. So 5 liters of blood per minute. That is a ton of blood. So why am I even telling you this in the first place? Because the factors that affect our systolic blood pressure also affect our cardiac output. In fact, it's reverse. The factors that influence our cardiac output influence our systolic blood pressure. So we can actually manipulate these variables to either raise or lower our patient's blood pressure. They're driving force for circulation. Remember, pressure drives that blood to move places. So what can affect the heart rate? Well, we know that we can speed it up with sympathetic stimulation, and we can lower the heart rate with parasympathetic stimulation or drugs like digoxin, amiodarone, calcium channel blockers, specifically the non-dihydropyridine kind, beta blockers, and tons of medications. So when we increase the heart rate up to a point, we can increase the cardiac output and we can increase our systolic blood pressure. And when we decrease our heart rate to a point, we are going to lower the cardiac output, remember, and we are going to lower our systolic blood pressure. Now, what about stroke volume? How do we change the amount of blood that our heart squeezes out? Well, stroke volume is in diastolic volume, what we start with, minus in systolic volume, what we end with. Or the amount of blood that started minus what is left after contraction. So this gives us an amount that's usually around 70 milliliters. Well, stroke volume is dependent on three things. No cap, sorry, bad pun, but it's CAP, cap, where it's influenced by the contractility, the afterload, and the preload. So preload is the amount of blood that is in the heart when it is done filling, our end diastolic volume, meaning that the preload is the maximum amount of stretch on the heart when it is most full of blood. So preload is really dependent on our venous return and the time that is allowed to fill. So we can actually increase our preload, our patient's preload, by increasing their venous return and allowing more time to fill. So this could be as simple as putting your patient's legs up, putting compression stockings on your patient's legs to increase venous return, or you could give them medications that slow down the AV conduction to a point, like amiodarone or metoprolol. Okay, now what is afterload? Well, this is defined as the amount of pressure that the ventricle must overcome to squeeze blood into the arterial system. Basically, it is the pressure in the aorta. The pressure in the aorta is pushing back against that ventricle. That ventricle has to squeeze harder than the aortic pressure to eject that blood. So imagine a pole vaulter as our ventricle. The afterload is like a bar that our pole vault ventricle must jump over. If our pole vaulter has to jump really, really high, then that pole vaulter might not have much extra room between him and the bar. In other words, if our afterload, the aortic pressure, is really, really, really high, then the ventricle will not be able to squeeze out a lot of blood because it can only generate so much pressure. Our ventricle can only jump so high. So if we decrease the pressure in the aorta by dilating our arterioles, then our ventricle can eject more blood. This decrease in afterload would allow for more blood to be pumped out. When we give drugs like angiotensin converting enzyme inhibitors, ACE inhibitors, ARBs, our sartans, or our alpha-1 antagonists, we are lowering the afterload. We are decreasing that pressure that's in the aorta that's fighting against our ventricle. So specifically, these medications would allow for less in-systolic volume, which would actually increase our stroke volume. This would increase our cardiac output and increase our systolic blood pressure. Okay, but what about contractility? Well, what even is contractility? Well, what about how hard our heart is actually squeezing? Our contractility is when we squeeze harder. So these are called inotropes. So when we increase our contractility, we make our heart squeeze harder, we're actually pushing more blood out. This will increase the stroke volume, which increases our cardiac output, which increases our systolic blood pressure. So an increase in contractility will generally increase our systolic blood pressure. Well, certain hormones in our autonomic nervous system can actually influence our contractility. So some of the most important drugs that influence our contractility that you're likely to see in practice are beta blockers, digoxin, are non-DHP calcium channel blockers. So beta blockers and our non-DHP calcium channel blockers will work to block our beta-1 receptors or directly decrease the amount of calcium that's actually flooding into our cardiac myocytes, which will decrease the force of contraction. Remember, calcium is directly associated with how hard something constricts. just like in smooth muscle, just like in skeletal muscle, just like in cardiac muscle. Now, beta blockers also have some other properties which make them useful in managing congestive heart failure, which means that our heart doesn't pump well enough. Remember, congestive heart failure simply means that our heart isn't pumping well enough. But on the other hand, we have digoxin. This is from the foxglove plant. It's a derivative from that, and it's called a cardiac glycoside medication, and it can be very, very dangerous. But it is really good at slowing down the heart rate while increasing our contractility. Okay, so how do we increase our patient's systolic blood pressure? Well, we know now that we have to increase the cardiac output. Well, how do we do that? Well, we can increase the heart rate to an extent, and we can increase the stroke volume by increasing our preload, our stretch, by decreasing our afterload. Remember, our pole vaulter has to jump over that aortic afterload, and also by increasing our contractility. Now, what about that pesky diastolic blood pressure? It never gets any attention. It's not as popular. Well, what is it determined by? Let's think about it. The diastolic blood pressure is really just that pressure in the arterial system when there is the least amount of blood from the heart. So this is the minimum amount of blood. This is when we are all out of blood, it's gone other places. This is the pressure at that very exact moment. So what controls that pressure really? Yes, it is the total peripheral resistance. It is really determined by how constricted our arterioles are. Now, if there's not a lot of blood in our arteries, then the only thing that is keeping our pressure up is how hard our arteries are clamping down. Now, you can also increase the total peripheral resistance, remember our TPR, by increasing your blood viscosity. Like if you're a Sherpa and you had a ton of red blood cells, remember Sherpas, they're the people that help you carry stuff up mountains. So they live at really high altitudes. They have tons of red blood cells. So this is called polycythemia or polycythemia vera. Then your blood would be thicker than syrup and your TPR would be elevated. But normally, under normal circumstances, this is influenced by our arteriolar clamps, our alpha 1 receptors. So we can actually increase our TPR and increase our diastolic blood pressure by clamping down really, really hard. How do we do this? Well, we can give alpha 1 agonists like norepinephrine, phenylephrine, or oxymetazoline, better known as Afrin. All of these will increase our total peripheral resistance, which will increase our diastolic blood pressure. Now, how do we lower our diastolic blood pressure? Well, if we have less blood volume, this will lower the amount of pressure, but we can also relax our arterioles by giving alpha 1 antagonists like hydralazine. This will decrease our total peripheral resistance and lower our diastolic blood pressure. So now that we're starting to become these blood pressure masters, I'm going to talk about a concept that is talked about all the time. And really, a lot of people don't understand really what is behind the mean arterial pressure. I'm talking about the MAP. You're going to hear this word thrown around all the time. This is people treat this like the holy grail of perfusion, meaning, are our organs getting blood? I don't know. Check the MAP. So the mean arterial pressure is exactly what it sounds like. Always break words down. You have to understand that it's the mean or the average pressure in the arterial system, meaning that if I took one cardiac cycle, meaning one squeeze and one relax at the heart, what would the average pressure be? Well, is it as easy as maybe adding the blood pressures together, the two numbers, and then dividing by 2? That's how we get the average, right? Well, it's not that simple. But the simple answer is that most of the heart's time is spent relaxing in diastole, which means that the diastolic blood pressure is king. It means that the diastolic blood pressure has more influence on the mean arterial pressure than the systolic does. Okay, so this is super, super important. I'm going to say it again. the diastolic blood pressure has more influence on the map than the systolic blood pressure. Why is this so? Because the heart spends most of its time relaxing. What's the average pressure? Well, the average is the mean between all of the pressures, right? So it makes sense that if our heart spends more time relaxing, it's going to have a greater influence on our mean arterial pressure. So in fact, the heart spends about 2/3 of its time in diastole and about 1/3 of its time in systole. Now, what is the formula for calculating MAP? Well, it's 2/3 times the diastolic pressure plus 1/3 of the systolic pressure. It's that easy. So when we get a pressure of, say, 120 over 80, we get about 93 for our MAP, meaning that in one heart squeeze and relax, the average pressure that's in the arteries is about 93 millimeters of mercury. Okay, so this is the critical part. A general rule, and yes, a very general rule, is that you want to keep your patient's MAP above about 60 to 65, depending on who your provider is. If you want to keep blood flowing to the organs, anything less, then you run the risk of killing those tissues and organs because they're not going to be getting enough blood. So if our patient comes in and their blood pressure is 90 over 35, you do a quick calculation, or really the machine's going to do it for you, and their MAP is about 53. Well, if they're a young, healthy adult, this is very scary. This is not going to sustain life long term because those organs aren't getting the blood they need. If the average pressure is, say, in the 50s, their organs are not going to be perfused all the time. So how do we raise the MAP? Well, of course, you have to fix the underlying issue. But if you need a really quick fix, what is the most efficient way to quickly increase the MAP? Well, we know that the MAP is more dependent on the diastolic number. So we could increase the diastolic. But how do we do that? Well, we have to increase our total peripheral resistance. How? By clamping down on our arterioles. How? By using our alpha-1 agonists like norepinephrine. So this is a drug that is used tons in ICUs. It's also called Levophed or Levophed. Now, this is an alpha-1 agonist that clamps down our vessels super hard, which increases our total peripheral resistance. We know that if we increase our TPR, we're going to increase our diastolic blood pressure, and we know that our diastolic blood pressure has much more influence than the systolic blood pressure. Now, a golden rule to remember is that the pressors, the clampers, they will work a ton better when you have some fluid to clamp down on. So it's always a good idea to bolus your patient with some isotonic fluid like normal saline or lactated ringers before you clamp their vessels down. So a really popular term is the fluid bolus is like the gas, right? And the pressors are like actually pressing down on the gas pedal. So I know that was a ton of information, but hopefully I've opened your eyes to the wonderful world of blood pressure, cardiac output, and total peripheral resistance. So thank you so much for taking the time to learn with us today, and I hope that you like and subscribe for more content. Thank you.